3 words. That's all it takes. Bone on bone. A doctor points to an image, says those 3 words, and for millions of people, that's the moment everything changes. They stop moving. They start waiting. They accept a future defined by pain, limitation, and eventually, a surgery they were told was inevitable.
But what if that story is wrong? What if bone on bone is one of the most misunderstood, misused phrases in modern medicine?
What if bone on bone is one of the most misunderstood, misused phrases in modern medicine? That's exactly what the research says, and that's what this video is about. Every year, millions of people walk out of orthopedic appointments with the same diagnosis: osteoarthritis, significant cartilage loss, bone-on-bone contact. And almost every one of them is handed the same roadmap. Manage the pain. Wait for it to get bad enough. Then surgery. What they're rarely told, what the research has been screaming for over a decade, is that the relationship between what shows up on that X-ray and how much pain a person feels is far weaker than anyone led them to believe. By the end of this video, the phrase bone on bone will mean something completely different to you. And the options available, options most people are never told about, will be clear. First, what does bone on bone actually mean? The knee joint sits between 2 major bones, the femur above and the tibia below. Cushioning that space is a layer of cartilage, smooth, slick tissue that absorbs impact and allows the bones to glide past each other without friction. Over time, through age, overuse, injury, or genetic factors, that cartilage can wear down. When it wears down significantly, the joint space visible on an X-ray narrows. In severe cases, it appears as though the bones are directly touching. That is bone on bone. It is a description of an image. It is not a description of how someone feels. It is not a prediction of function. And it is not, as it's so often presented, a verdict. Here's the statistic that puts all of this into perspective. Research has consistently shown that up to 40% of people with moderate to severe osteoarthritis on imaging, what would be clinically described as bone on bone, report absolutely no knee pain. None. And the reverse is equally true. Plenty of people with relatively normal-looking knee X-rays are in serious, debilitating pain. If the X-ray doesn't predict the pain, something else is driving it. Knee pain in osteoarthritis is the result of multiple overlapping factors. Cartilage loss is just one piece, and often not the most important one. Factor 1: inflammation. When the synovial membrane, the tissue lining the joint, becomes irritated, it produces inflammatory chemicals that directly trigger pain signals. Over time, the nervous system can become amplified, trained essentially, to produce more pain than the physical damage alone would warrant. The brain learns to expect pain from that knee, and so it delivers it. Factor 2: muscle weakness. The quadriceps, the muscles along the front of the thigh, function as the primary shock absorbers for the knee. When they're weak, the joint itself absorbs forces it was never designed to handle. In the majority of people with chronic knee pain, measurable quadriceps weakness is present, and critically, it's one of the most fixable factors on this list. Even when tissue damage hasn't changed. This is documented neuroscience, not speculation, and it explains why 2 people with identical X-rays can have completely different pain experiences. Factor 3: central sensitization. This one surprises most people. Factor 4: fear avoidance. When someone is told their knee is bone on bone and beyond repair, they stop moving. Naturally, intuitively, it feels like the right thing to do. But inactivity worsens every single factor on this list. the muscles weaken further, inflammation increases, sensitization deepens, and the pain gets worse, which confirms the belief that movement is dangerous.
It becomes a self-reinforcing cycle, and the diagnosis, those 3 words, is often what starts it.
Now, here's where the mistake happens that keeps most people stuck for years. Hearing all of this, it's easy to think, fine, so just move more. But doing the wrong type of movement at the wrong intensity absolutely can make things worse. What the evidence actually supports is more specific than that. And some of it will be genuinely surprising. Here is what decades of research on knee osteoarthritis treatment actually supports, starting with the most impactful. Number 1, targeted strength training, specifically progressive quadriceps strengthening. Large-scale studies, including data from the Osteoarthritis Initiative, have shown that patients who strengthen the muscles surrounding the knee experience significant reductions in pain, improvements in function, and in many cases, delay or complete avoidance of surgical intervention. Number 2, weight management. Every pound of body weight generates roughly 4 pounds of force on the knee joint during normal walking. Modest weight reduction, even 10 to 15 pounds, meaningfully reduces joint load and has been shown to reduce pain independent of any other treatment. Number 3, pain neuroscience education. This sounds intangible. The research is not. When people understand that their X-ray is not a sentence, when they understand the science behind central sensitization and fear avoidance, their pain measurably decreases. Studies on pain neuroscience education consistently show improvements in pain levels, function, and psychological well-being. What a person believes about their body directly affects how much pain they experience. That is not a philosophical claim. That is documented in the peer-reviewed literature. Number 4, low-impact movement. Cartilage receives no direct blood supply. It gets its nutrients through movement, through the compression and decompression of the joint during activity. Prolonged rest does not heal cartilage. Appropriate, graded movement does. Swimming, cycling, walking on even terrain, and Tai Chi all carry strong evidence for reducing knee pain in osteoarthritis. They load the joint beneficially without excessive stress. And what about injections and surgery? Corticosteroid injections can provide meaningful short-term relief for some patients. But evidence for long-term benefit is limited, and repeated injections may have downsides for joint tissue. PRP, platelet-rich plasma, is an evolving area with promising early results, but the evidence base is still maturing. As for total knee replacement, for the right patient, at the right stage, it is a legitimate and effective procedure. But a 2017 study published in Arthritis and Rheumatology found that up to 1/3 of knee replacements performed may not have met the clinical criteria that justify surgery. 1 in 3. That is not a fringe finding. That is a peer-reviewed journal raising serious questions about how often this surgery is being offered before conservative treatment has been genuinely exhausted. None of this is to say that cartilage loss doesn't matter. It does. It's real structural change, and it deserves real medical attention. But structural change on imaging does not determine functional outcome. The human body is more adaptive, more capable of compensation, strengthening, and pain reduction than a single X-ray can capture. People classified as severe on osteoarthritis imaging go on to complete hiking trails, to return to swimming, to play with their grandchildren without pain. Not through ignoring the diagnosis, but through understanding it accurately and responding to it intelligently. The question worth asking any orthopedic provider is not simply, when should I have surgery? What is the most structured, intensive, evidence-based conservative treatment program available to me before surgery is considered? That question changes outcomes. If this reframed something, share it. Someone in your life has almost certainly been handed this diagnosis and told there's nothing left to do. This video is for them. And if knee rehabilitation is the next step, what a proper evidence-based program actually looks like, the specific exercises, the progressions, the timeline, that's covered in the next video. It's right there. Don't stop here. Bone on bone is a description of an image, not a forecast. Pain is driven by inflammation, muscle weakness, nervous system sensitization, and the stories we're told about our own bodies. And the evidence says there's more available than most people ever find out.